The thoughts and opinions on Just Some Podcast are of the hosts and guests and do not represent the views of organizations that employ them or they volunteer for. They are also not responsible for spontaneous black holes or nuclear wars that may occur. You have been warned.
Welcome, everybody, to another fun-filled and exciting episode of Just Some Podcast for 2020, our first one. This is Tom.
Hey, this is Ben. So, we kind of took a little bit of a hiatus there in December, and we did the Christmas episode and some holiday myths, but then we just kind of took some time and recharged the batteries, spent some time with family, and treated a shit ton of flu in the clinics, and yeah. So, how are you, man? Been a little while since we talked on the podcast anyway.
I am swell, I guess. Oh, great. That court order's finally done with, so we can, talk. I'm kidding. There's no court. Yes. No, everything's good. You got some in-laws at the house doing my own Clark Griswold special at the moment. But everything's great. Had a good Christmas. Had a great New Year's.
Good.
Busy at the office. How are things your way?
Pretty good. We did the Christmas and New Year's thing, and it was just nice to just do family stuff. I think New Year's we went down and played games, and I drank all of one beer and just kind of kicked back and relaxed and just enjoyed the time. Kind of recommended vacation because I have too much PTO, so I had some time off around that time as well. So yeah, it was good.
Yeah, I found myself not even wanting to drink. Like, I had a bottle and I was like, yeah, New Year's Eve, we're gonna have some drinks, and
right, yeah.
I found myself in my lazy boy going, nah.
Nah, not worth it. Yeah,
I guess I've hit that age where I'm just like, I would much rather wake up tomorrow without a hangover than have a couple drinks tonight. So there you go.
Well, it had to happen eventually that we would grow up, but
I refuse to believe I'm fully grown up.
Fair enough.
But overall, it was some good time off. I missed the show, though, so I'm ready to jump right back into it.
Me too, man. It's been good. I know we've been seeing all kinds of stuff on Facebook and stuff going, hey, where is Just Some Podcasts? Like, we want more episodes, and we've had all kinds of people sharing it and recommending it, and that's been great to continue to see that. And so we have a waiting audience that is just thirsty for some JSP knowledge, and so we're ready to dispense such knowledge, hopefully.
Dispense.
Yeah,
that's a good word for it. Let's see here. I'm trying to think of some other words, but yeah, we're just, for this episode, we're gonna stick with dispense. But yeah, let's get into it. So let's see if we can knock the dust off of this and do a social media round. What do you say, Ben?
Yeah, okay, let's see here. me.
Me.
Okay, yeah.
That's E flat.
Oh, all right. Well, you can find us on Facebook, Instagram, Twitter, and YouTube, all at Just Some Podcast. You can find us on the web or at www.justsomepodcast.com. You can email us, admin@justsomepodcast.com. Don't forget, you can also find us on Helium Radio. That's Helium Radio After Dark, Channel 2, Thursday nights, 9 p.m. Eastern, 8 Central. And wherever you can find a podcast, we are probably going to be there, including iTunes, Spotify, Apple Podcasts, Google, wherever. Tom, what else can they do to help us out?
Well, as they did plenty during the holiday shopping seasons, which we surely appreciate, but they can continue to while all these great deals are out. If they go to the JSP website and they scroll down to just about the bottom, there is a link to Amazon shopping that they can click on before they do any of their shopping. It'll then take them to the Amazon site. They can do their shopping, and any of the shopping they do after that point will help us out and give us a what is it an affiliate proceed or something like that? I don't
Yeah,
know. But the money
Amazon
goes,
affiliate. Yeah.
yeah, it goes to us and that helps out the show. And we truly appreciate it. They can give us some ratings and reviews, good or bad. We do appreciate all of the above. And we do reply, as people have found out, regardless
Sure.
of the info. Do we want to talk about that for a second? So yeah, let's talk about that for a second, because I don't know if everybody knows about that. So somebody, I think they specifically directed it towards me. Right?
Yeah, it was pretty much, yeah.
Yeah, no, dead on. They directed it towards me.
That's trying to be nice, yeah.
So what it was is, in our episode during Halloween, we referenced the story you may have missed about an Australian woman who threatened to pass out chickenpox laden candy to children to try and infect them.
Yes.
To prove that chickenpox was not deadly and whatever other insane reasons a person would have to do something like that. And I made a comment. Well, I made a bunch of comments, but such as, I hope a kangaroo eats her baby or something like that, in reference to the famous Seinfeld line of a dingo ate your baby.
Right.
And somebody did not appreciate that at all. And they gave us a bad review. And you know what? That's fine. That's their opinion. I still appreciate that they took the time to even write to us. I like that. I would say, though, that someone participating in bioterrorism is not really a personal opinion that we at JSP support. And no, I'm going to go ahead and take a full stand against people trying to infect children with viruses of any sort. So I'm going to still have to say I respectfully disagree with anything you have to say if you support that type of action. So go ahead and write us and let us know your opinion. But that's probably going to be met with some resistance, just to let you know.
I would just like to add that kangaroos are herbivores. They eat grasses, flowers, leaves, ferns, moss, and some small insects. They do not, however, eat children, and therefore it was a joke. And yeah, we'll go from there. They're herbivores.
And speaking, side note, not that any of this was planned, have you seen what's going on in Australia?
Yeah. All the fires and bad stuff.
Crazy. So to any of our listeners, and I know we do have some in New Zealand and Australia, not that you're taking the time to listen to us, but if you do, our hearts go out to you. Please stay safe. The world is thinking of you at this time, and we just hope that you make it through healthy and that things can hopefully be rebuilt and everybody can try and get back to some form of normalcy when this is all over.
Yeah, I mean, you summed that up really great, man. I don't have anything to add to that. So,
of course, you're talking about a group of people that eat Vegemite, so I don't really know what normalcy is. So
I thought that was the UK.
No, Vegemite is totally Australian.
Yeah, okay. I thought it was popular.
I'm sure of this. Vegemite's Australian.
If
Kiwi is New Zealand. Not the fruit. That's the term.
If you're from Australia, New Zealand, or the UK and you eat Vegemite, particularly if you're from the UK and it's big there, email me and let me know, and I'll send it to Tom, admin@justsompodcast.com.
You're going to lose, my friend.
No, I'm not. Are you ready to get into our story that you may have missed?
Yes, sir. I believe I am ready.
Well, so I went out because, as you have, I'm sure, read on when you downloaded this episode, we are going to be talking about weight loss medications. And so it's the weight loss medications. Why are we talking about that now? It's the first of the year. Oh, New Year's resolutions. So I went out and tried to do some research on that, particularly into why New Year's resolutions tend to fail. So, according to the U.S. News and World Reports, approximately 80% of New Year's resolutions fail by February. So, here's 4 common ways that they fail, and hopefully you can, if you are one that makes resolutions, you can take this information and alter your resolution to make it more successful. But the first one is that your goals aren't clear. So, maybe you're not setting a clear goal as far as what you're wanting, and it's just very vague. Like, I just want to be healthy. Well, what the hell does that mean? That may be different for everybody. So, make it more clear. The second one, you feel overwhelmed. Change is not easy. No one really likes change. And so now you're going from, say, you used to sling back a 30 pack of hot wings with some blue cheese. I'm looking at you, Tom. And now you've decided, you know what, I'm not going to do that anymore. I mean, that's a pretty significant change. So it may just kind of feel like you're overwhelmed and you're not able to handle that really well.
So my clear goal is to go down to 20.
Yes. See, that's a clear goal, and you won't feel overwhelmed. And then maybe 15. The third one, you feel discouraged. So you kind of become impatient, and I want to lose 50 pounds, and you wake up the next day and you're still the same weight you were, and so now you're like, well, screw it, I don't want to do this anymore. So you get kind of discouraged, and then you just give up on it. And the last one is you're just not ready for change. I think as healthcare professionals, I think we all are kind of aware of that, particularly like, say, with smoking, that's a big one. Patients who come in and I'll ask, are you a smoker? And they'll be like, yeah, and I'm not ready to quit. Don't even talk to me about it. Cool. All right. I know where we're at. So it's like you have to be ready to change and willing to change in order for it to actually work. If you're making this resolution because your wife wants you to, or your significant other, or your family, or whatever wants you to, then it's more than likely not going to succeed. So, Tom, those are kind of the 4 main points of failure. What are your thoughts on some of that?
Honestly, they all seemed reasonable and clear and to the point and very common sense. Like when you said them, I'm like, wow, that all makes really good sense. We probably should have all thought about that ahead of time, to be honest. Especially the last one being, it seemed very definitive. Like, oh yeah, you should probably have already known that ahead of time going into it.
Yeah, but I do think sometimes peer pressure can cause you to want to vocalize a resolution to change something, whether it's smoking or weight or whatever, and your heart's not really into it, so you're not going to do it. And so then that's the ones that the gyms are real busy on January 2nd, and then February 1st, there's right back to normal.
Honestly, that is one of those things, like, I don't even like going to the gym like the first 2 months of the year, because it's like, okay, I don't feel like waiting 25 minutes to get down to a pull down machine, because I support people going to the gym. It has nothing to do with that. If you're trying to improve yourself, completely with that. But you couldn't have done this in, April. It always, January, February always happens. So it's just a thing. But no, I also like, I think the first point also needs to be more probably prominent to most people is, don't set a goal of, I need to lose 100 pounds. How about you set a goal of, I need to lose 15 pounds? Like, let's start there. And once you lose 15, then it could be like, I need to lose 10 more pounds. Do something very reasonable and try and be piecemeal. And then next thing you know, you'll have lost 100 pounds. When you set that Everest goal and you're still at the bottom of Everest, guess what?
Looks really tall.
Yeah, exactly. Suddenly I don't want to climb Everest anymore. But that's where you're at.
And on the one about getting discouraged, this is one that I really stress with my patients when they do come in and talk about weight loss, medications or dietary surveillance or whatever the case may be, is, you're going to have days where you're just going to eat like crap. It's going to happen. We're humans. You're going to have a stressful day or whatever the case may be, and you're going to plow through an entire pizza, whatever the case may be. In order to not get discouraged, you kind of have to, that next day, you had to, what I call it etch-a-sketch it. You just got to erase it. It's gone. don't fret about it, move on. Because what happens is that one bad day is going to go, well, shit, I screwed yesterday up, so now might as well not do this anymore, and then you just kind of go down that path. Whereas if you etch a sketch it and move on, you have a higher chance of success.
Exactly. If you have one bad day out of 30, there's no point in throwing away the other 29.
Yeah.
I mean, one bad day does not ruin a month, but sometimes it seems so easy to us to get discouraged and just say, okay, well, I had this one setback, so screw it. I can just throw away everything. But I've also tried to tell people, both in and out of the office, when people have talked to me about it, and I've said, you didn't get fat overnight. So how do you expect to lose the weight overnight? I don't understand why you're expecting this to happen. I mean, I'm a big guy myself, and I try to say the same thing. I try to remind myself when I get discouraged is like, hey, you didn't balloon this way. It took you a couple years. Why are you expecting results any faster than what it took you to get here? So, but we all know the basic principles, and we're going to discuss some of that. And hopefully everything we're going to discuss over the next 45 minutes is going to help support everything we just discussed. So do you want to get into it? You ready?
Yeah, I mean, I think that particularly working in family practice, this is something that we handle a lot of. There's lots of obesity, particularly in the United States. And so people want to come to the office for weight loss medications or, assistance with that. And so we really thought that we would hit some of the more popular medications that are out there to help with weight loss, kind of go over some of the do's and the don'ts with that, and hopefully give you some good education along the way with cracking jokes from Tommy and I. So, yes, sir.
And I was just going to say, I think in the interest of full disclosure to the audience, I think it's only fair that I tell them I'm on one of these. I don't want to tell them which one because I don't get paid, or I don't want them to think I'm biased towards one of these medications, but I am currently on one of these medications. And so I do have some skin in this game. Like, I do pay attention to some of these indications, etc., because they apply to me. So this is a subject matter that is important on a personal and professional level. So this isn't just something where I researched it because I thought it was an interesting topic. This is something that literally every day I put into my body. And so it has become a little bit more important than just a prescription.
Full disclosure then, I have probably 4 of the 5 that we're covering 5, I think. 4 of the 5 that we are covering, I have personally tried as well. So it's not something that you're going through alone if you are going through this. So
exactly, we are in this boat with you. So
with that being said, let's jump into the most frequently used medication, a medication by the name of phentermine or phentermine. From 2008 to 2011, 25.3 million prescriptions of phentermine were issued in the United States. Just so you understand the mechanism of action, it is an amphetamine analog. So it enhances activity of the sympathetic nervous system, which modulates norepinephrine, also serotonin and dopamine. That is kind of how it helps to work, but it can potentially increase blood pressure as well. Something that I didn't realize, Tom, this medication was originally approved in 1959 by the FDA, which I thought was kind of interesting. I mean, this is the one that's been around the longest, obviously. Has shown positive efficacy to be used for short-term weight loss, according to an article in the AACE. In this particular study that was studied over 12 weeks, 3,411 patients were in the study. They lost an average of 3.45% of their body weight from baseline. Phentermine was the highest on these because this was actually an entire study of all of the medications. Phentermine was 3.75%, followed by Qsymia at 3.63%, Contrave at 2.66%, and Belviq at 1.84%. Dosing of phentermine generally is 37.5 milligrams daily, although I have seen it dosed differently. With patients on this, I do recommend to them, if they are phentermine naive, to break the tablet in half the first few days, just so they're not getting this major rush, because it is an amphetamine. It's a mild amphetamine, as we stated earlier, and so it can kind of cause people to have a little bit of extra boost of energy. It does kind of curb the appetite. It also makes you very thirsty, is one of the big side effects of it, which I tell patients is a good thing, because that's going to make you increase your fluid. One of the biggest issues that I do watch for, and I generally try to have them follow up at least monthly on this medication, is it can increase your heart rate and blood pressure. And so generally we monitor blood pressures to ensure that they are not getting too high. That's particularly because it is a vasoconstrictor, as I explain to my patients. So generally this is not a medication that I'm going to use for a patient that has any type of cardiac history. And so that's one of the questions I ask before I use this medication. The other thing that I did find in my research was from the Mayo Clinic, is that there have been some incidents of coronary vasospasm related directly to...
Well, that sounds like a great night.
Right? Yeah. Related directly to the phentermine usage. So you need to be particularly cautious with individuals with a history of smoking or underlying atherosclerosis. So you just basically need to be vigilant and educated about the use of phentermine. Any questions on that one, Tom? Anything I didn't cover?
No, I'm pretty sure you covered it. you covered it, sir. But no, 1959. So I was just wondering, because I've seen shows where they talked about amphetamines that were sold in European countries, in particularly Germany, over the counter as stimulants as far back as the 30s. I can't remember the name of it right now, and I don't want to get off and Google it at the moment. But yeah, so I wonder like how down the line someone was like, hey, that guy sure is taking a bunch of whatever that is. I can't think of the name of it right now, but it had like a very common name. And I just wonder how they progressed and got into identifying that. And then the FDA saying, hey, yeah, sure, that's a weight loss drug. And there we go. So
the only thing I didn't mention that I probably should have is phentermine is a Schedule 4 controlled substance. So there's a very low potential for abuse. And it is widely interpreted as short-term administration as approved by the FDA, which is supposed to be up to 12 weeks, although there are some cases of using phentermine longer. Some studies show that it doesn't have any significant adverse effects as opposed to the short-term use. But because it is a scheduled drug, then there are some advanced practice providers that may not be able to prescribe this depending on your state's laws. Tom, what do you have for us next?
Well, the first one is a medication that you just spoke about, and I'm going to talk about Belviq. And I think the reason I want to talk about that first is because you just spoke about a stimulant-based medication, and this one does not work off stimulants. This is a serotonin 2C receptor agonist. The mechanism of action is actually based on a decrease in food consumption to promote satiety by selectively activating the 5-HT receptors and basically tricking your hypothalamus into thinking that you're full.
Interesting.
Now you don't want to eat as much. All this information, as a matter of fact, all my drug information, the primary source is going to be the websites for the drug information themselves. So if you want to look it up or deep dive this, you could really get into it. There is a ton of information. I'm condensing it down for the audience. And there's a lot of really cool words that you're going to need to Google Translate that I'm not going to attempt to say a lot of them, but that's the basis of it. It will say, spoiler alert, things like exact mechanism of action not known, and I'm sure there are some legal reasons for that, but that's the basics of it, is that it's basically tricking your brain into saying, hey, you're full, but you're not. And that's okay. And so by tricking your body into thinking that you're full, you're going to consume less calories. And as we all know, calorie deficit is the truest measure. I mean, all diets are truly basically a calorie deficit. I mean, keto is great, and whatever diet you want, they're all great, but they all basically are forced calorie reduction. And so that's what Belvique's main characteristic is. It is a Schedule 4 drug, as we discussed with the phentermine. It's metabolized by the liver, so that's also important information to know. So if you have a patient that is interested in consuming this medication, it's probably really good to know if they have any sort of liver history. The main two indicators actually are BMI of 30 or a BMI of 27 with a comorbidity such as hypertension, dyslipidemia, or diabetes. Diabetes type 2, I should say specifically. They have some issues with blood sugar, which I'm going to get into shortly. So there's not really a lot of studies for type 1. They actually don't really specifically recommend this medication for type 1, so type 2 diabetes. So Belvique is also known as Belvique, Belvique XR, or lorcaserin is actually the medication. The brand name is the Belvique. So it comes in the 2 dosages. The 10 milligram, this I thought was funny. It's Belvique is 10 milligrams, which you take twice per day, or the Belvique XR, which is 20 milligrams once per day.
Well, that seems logical.
I know, but I'm just like, why don't you just make it all Belvique XR and just make it easy on everybody? Okay.
Well, my guess would be that
money. Yeah.
Yeah.
Yes. They are all enteric coated, so you do not want to crush or alter the medication in any way. They're made to be taken in that form only. The contraindications for Belvique, or the main contraindications, are pregnancy and sensitivity to the medication itself. Some of the most important things right off the bat that your patients are going to want to know, or that it's been my experience when people want to talk about these types of information or medications, that the patients want to know, are some of the adverse reactions or things that are going to happen. So the main ones that you're going to be wondering about with Belvique are going to be GI disorders, nausea, vomiting, diarrhea, constipation, dry mouth, fatigue. Here's some ones that are more specific to Belvique: upper respiratory infection, nasopharyngitis, and UTI, back pain, headache, dizziness, and those are the more common side effects that you can get with Belvique. You can also have a change in attention or memory. You can have mental problems such as hallucinations, depression, or suicidal ideation. You can have a decrease in blood sugar, which again goes back to the issues we were talking about with diabetes earlier.
Right.
Here's another one that I don't remember specifically seeing with some of the other medications I researched, was painful erections. So if you are a male or you are prescribing this to a male, again, I did not see anything that was like, oh my God, or did any research where they said this was a common problem, but it was definitely something that was brought up. And if you have a patient that have a history of priapism or is prone to priapism, you may not want to prescribe them Belvique.
Wow.
Slow heartbeat and increased prolactin are also some issues that have come up with Belvique. So
it's funny that you talked about erections and then come up was your next.
Shut up. So I will tell you, there are some with some of the other one of the other medications more specifically, there are changes, but I did not see any changes in dosages with Belvique. Once you start this, it is the same 10 milligrams the entire time. That is a pretty nifty nice. Now, there are some recommendations. It says like if they do not lose like 5% of their target weight within like 12 weeks, I believe, that it is recommended to discontinue medication. Clearly, it's up to the provider and the patient. Like if the patient feels like he or she is doing well, you can always have that conversation. It's just the recommendation of the manufacturer. And I would probably say it's because A, there's some mechanism of action that's not correcting the calorie deficit, or B, that the possible side effects that can come along with long-term use of the medication may not warrant the risk for the low amount of weight loss that you're getting from it.
Which makes sense. I mean, yeah, it's going to be a risk benefit assessment. And I would bet that the majority of these medications are going to carry that a very similar.
Oh yes, they are.
Yeah.
All the medications I researched had that same. I don't want to say stigma, but I mean they all had those trip points. Like, hey, if they have not reached this much at this point, you need to either bump up, cut back, or get off. Another thing, and I guess I should have covered this to the point, is not only is this supposed to induce calorie deficit, you are supposed to be changing some lifestyle along with these medications. Belviq is no different. You're supposed to be changing diet as well as getting into a healthy exercise program to help promote this calorie deficit to make the medication work better. So it is supposed to be a combination of those things that are helping you with the weight loss. So it's not magic in a bottle. If that's what you're looking for, this is not the episode where we discuss that. Okay, this is helpful information. These are helpful medications, especially if used properly, but you have to know that you are still going to have to put in some work.
Yeah, that's one thing I do stress with any of my patients that come in for weight loss, and I think that's a good point, is that I tell them, this is not a magic pill. If you don't do anything to change and you just take this medication and don't change a damn thing, it's not going to change anything. You're not going to get anything out of it. So you have to, and generally what I tell patients is, I don't care if you count calories, count carbs, do keto, do Atkins, do whatever diet plan or whatever you want to do, but you got to do something and you got to stick with that. And then, like Tom said, with making sure that you're getting into increasing your activity and exercise, these are just a kind of an adjunct to that. It's not in place of that. Why don't you go on to your next one, since there's only 5 of them?
All righty. So the next one is Qsymia. And Qsymia is a combination medication. It is a combination of 2 old-timey medications. And so somebody at Vivus figured out if you take something old and you take something old and you put it together, it made something new, apparently. And what it is it's phentermine and topiramate extended release, and they put together in varying ratios. And it's a step-up process medication. And what I mean by that is, as I'll explain here shortly, is it's piecemeal. So you start at one dosage and then you increase it. So what it is it's phentermine, which we already discussed earlier, and topiramate extended release, which is an anti-epileptic drug. And those together, it helps basically. It's not just a boost your metabolism, because it is a stimulant, but it's actually more of basically causes a temporary anorexic state where your body just does not want to eat. It's not a specific mechanism of action like the Belviq. It causes the same thing through a different receptor. It just says, hey, you don't want to eat. And your body's like, cool. And now you don't want to eat. But it's the same as in, you still are supposed to be doing this as part of a healthy diet. Like, you don't want to starve to death. You just don't want to eat constantly. And then you also want to add in, again, working out, some type of cardiovascular work, etc. The same indications as before, BMI of 30 or 27 with a comorbidity. Limitations of use, such as with Belviq or with Contrave, as we're going to see, the effects of Qsymia on cardiovascular morbidity and mortality have not been established, etc., etc. So, I mean, they're trying to say is, hey, this is a safe drug, but you need to know that, bad things can or could happen. I mean, I think we all understand that there are those risks whenever we're taking these types of medications. So just be a good provider and make sure you lay out all the pros and cons, as you should be with any medication, to your patients. So let's talk about the dosages for just a second, so then we can talk about how to apply them. So the first number I'm going to talk about is the phentermine dosage, and then the second number I'm going to talk about is the topiramate extended release number. So the first dosage is going to be 3.75 milligrams, like I know what numbers are. And the second one is going to be 23. So 3.75, 23. The second step is going to be 7.5 over 46. The third step is 11.25 over 69. $69, dudes. Everybody loves Bill and Ted's Excellent Adventure Bogus Journey. And 15 milligrams over 92 milligrams is the final step. So what you would do is if you're dosing this out to your patient, the recommendations is the 3.75 over 23 you actually do for 2 weeks. All right, you get your patient on that, and then you start them on the 7.5 or 40 over 46 for up to 12 weeks. If they do not hit 3% over 12 weeks, you can either discontinue or escalate to the next dosage, etc. And then that is the step procedure it goes for different percentages. Like the next one, it goes at 5% for 12 weeks. But every 12 weeks, you're supposed to reassess with your patient their weight goals and weight loss and say, hey, where are we at? And are we making the type of progress we want to be making? I will tell you that once you hit into that 11.25 into that 15 milligram on the phentermine over topramate side, realistically, due to the fact that you're using topramate and phentermine together at that high of a dosage, you can't just take your patient off this medication any longer.
Right.
You are
Good
going
point.
to have to take this patient off in a stepwise fashion because now you have put them at risk for seizures. I mean, I'm not saying that they're at an undue risk. I'm just saying you have to make them aware that they cannot just quit cold turkey. If they're at 15 milligrams over 92, they can't just stop. that would be an unwise or undue risk to your patient. So there is a couple other big ones besides just the seizure that we need to talk about real quick. Some of the other contraindications for Qsymia is pregnancy, because pregnancy is a big no-no for all these diet drugs.
Makes sense. Yeah.
Yeah. Let's just throw out that you shouldn't be really dieting a lot if you're pregnant, period.
Right.
Maybe we should just lead off with that. Okay. Glaucoma, hyperthyroidism, or during or within 14 days of taking an MAOI. Okay. Or known hypersensitivity to any of the ingredients of Qsymia. I just want to say again, especially the glaucoma part, because this is also a medication that there was some stories and warnings in there about people after having been out for a couple weeks, they wake up and were like, hey, I'm having trouble seeing. So make sure, again, you pay attention to that. Again, it's something that's just as long as your patient is aware of what to look for and the steps that need to be taken, it can be taken care of. And it wasn't, or high rate, I should say, but it is certainly something that needs to be addressed when you're talking to them. Also, a big thing because of the stimulant is when dosing the patient, they need to be taking it first thing in the morning when they first wake up, because it does have a higher rate of insomnia if you take it at any other part of the day.
That makes sense.
So make sure your patients are aware of how to correctly use this medication, as well as the side effects that they need to be looking for. So what questions? I mean, obviously, I can't cover every part of every one of these drugs. So I'm trying to hit the highlights. There's a lot of different things. And if you are, again, I would tell anybody that is seriously thinking about either A, prescribing one of these medications, or B, taking one of these medications, call a rep, look at the website, educate yourself, use the information that these companies are providing. They want you to know about their drug. It's amazing how much information they're putting out there. So I'm trying to condense it down and give you the highlights and give you some education on how to safely prescribe or take these medications. So, Ben, what questions would you want as a patient or a prescriber if you were trying to do or trying to take or prescribe Qsymia?
Well,
or did I just do such a great job that you're like, no, you got it, man?
No, the only thing that I would hit on is because you did mention seizures earlier, and that's because the topamate, that's what it used to be for, was an old seizure medication. I don't know if you mentioned that. And then we also use it for migraines, and so that's the other place that we use that.
Yeah, I didn't mention. I mentioned the anti-epileptic, but I didn't mention the migraine preventative. Oh, how could I forget? Lots of fluid intake, not just because of the stimulant. It can make you prone to developing drum roll, please, everyone's favorite episode, kidney stones. Oh, buddy. And if that doesn't make you want to pee your pants a little bit, then nothing does. So,
well, yeah. All right. Well, let's jump into the next medication that we are going to cover. And we are going from oral medication to the injectable type, at least for this one. So we're going to go with Saxenda.
that's a good name.
It really is.
I like that name.
Liraglutide. It's a GLP-1. The other name that you might recognize this as is Victoza, which is what is used for type 2 diabetics. However, I suspect that what happened is they determined that, hey, this medication helps with weight loss, and maybe we should rebrand it and market it as a weight loss medication as well. So it is a GLP-1, as I said. So it stimulates the glucose-dependent insulin secretion, and it inhibits glucagon release and gastric emptying, and it binds to the GLP-1 receptors and stimulates glucose-dependent insulin release from the pancreatic islets. So that's how it helps with diabetes, and then because of some of the delay of gastric emptying can certainly help with weight loss because you feel full. And it also helps to decrease your food intake. Generally, the key dose that they want to get to is 3 milligrams daily, which is a higher dose than what is used as Victoza for diabetics. Recommended use is for those who are obese with a BMI greater than 30 or greater than 27 with at least one weight-related comorbidity such as hypertension or type 2 diabetes. So see, if they have type 2 diabetes and they're obese, it's a win-win.
That sounds really familiar.
Right?
This 30 BMI, this 27 with a comorbidity. It's almost like I've heard that somewhere.
Maybe once or twice. I don't know. In several studies, it has shown to cause more weight loss than placebo. And in one study that I found, real-world clinical effectiveness for weight management in Canada in Obesity, a research journal, showed that liraglutide 3 milligrams in combination with diet and exercise were investigated at 4 and 6 months post-initiation. And there was a significant change in body weight 6 and 4 months after initiation of treatment in the persistent subjects. Percent change in body weight in this particular clinic was 7.1% in the 6-month group and 6.3% in the 4-month group. But they estimated that all subjects lost approximately 6.5% of their body weight. The other particular benefit that you may have with this medication was, with it being GLP-1, is it has been shown to reduce major cardiovascular disease events in adults with type 2 diabetes. Adverse events, one of the big things that you need to know about is the GI side effects, and nausea and vomiting are the biggest ones, particularly as the dose is high. So what you want to do with dosing on this is generally start out at a lower dose of 0.6 milligrams daily. You're going to do that for a week, and then you're going to titrate it up to 1.2, then to 1.8, then to 2.4, and then to the 3 milligrams. So you're actually going to titrate it up over about 5 weeks. That does tend to decrease the dose-reported nausea and vomiting with this medication. Some other side effects you may see: diarrhea, low blood sugar, which makes sense because of it being a diabetes medication as well.
What?
I know, right? It's weird that it would cause sugars to be low.
We should have asked Jeff about this med.
I bet he talked about it in that episode. Some other side effects that are more serious but less common: it can, in some cases, cause pancreatitis, gallbladder disease, and some renal dysfunction. And then it does carry a warning. In rodent studies, it was associated with benign and malignant thyroid C-cell tumors. There has been no evidence of these tumors in humans, however, it is listed there. It's also contraindicated in pregnancy, as Tom alluded to earlier. And if they have any personal or family history of thyroid cancer or multiple endocrine neoplasia, you want to avoid this medication as well. I think one of the biggest hurdles with this medication is the injection, because you have diabetics who refuse or don't want to take a needle. And so then you have an obese patient who's trying to lose weight, and you're like, well, here, I have this medication, but it's you got to inject it every day. I can attest to the fact that the needle is small enough that you don't feel it. But it's still the needle aspect, and some patients will experience needle phobias. So that is Saxenda / Victoza / liraglutide. Any questions on that one, Tom? Have you had the opportunity to use that one or see it used?
No, actually, I have not. That's one of the few medications I literally did not have. I had very, very little information on. So when you were like, "Hey, I'll take that one," I was like, "Good." So I felt very happy.
I want to take that one because I do think it's an interesting medication, and I do see the benefits from it because it can help with diabetes and it can help with the weight loss. But again, it's just kind of getting patients onto that. Hey, you're going to do a daily injection.
Understandable. And again, like you said, I think once they can get over the needle aspect, I think it's no big deal at all. It's merely the phobia. Once they can
Yeah.
get over that phobia, it's smooth sailing. But you got to get somebody onto it. I just, again, Saxenda, that poof. Somebody give that guy a raise who came up with that
Right.
name. Like, man, that's a sell right there. But I think I'm ready to take it home. Bring it home with this last medication. Are you ready?
I am ready, sir.
So, last but not least, is Contrave, a combination medication that is not a controlled substance. The last two were Schedule 4s. This one is not. It is a combination medication of naltrexone and bupropion, extended release tablets. I will tell you that this is information directly from the manufacturer website. The second piece of information is a big black and white warning: suicidal thoughts and behavior. I don't know if that's what I would have let off with. I mean, props to the manufacturer for making sure that people were aware that this is something that people need to be aware of, both on prescription side and on the taking of the medication side. However, wow.
I suspect that has less to do with the manufacturer and more to do with the FDA.
Yeah, well, possibly. I again, in all fairness to Contrave, though, all the medications I've covered tonight, mental health has been something that has been stressed. Changes in mental health, suicidal thoughts and awareness,
Right.
hallucinations, suicidal ideation, etc., have all been part of the things that you need to be warning your patients of, or if you're taking the medication, you need to be aware of, because all these medications, and I think this is actually smart. I think this is one of the ways that medicine is moving. We can't just affect the physical. You have to get the person's mental into this. The body, yeah, like we could supercharge, a lot of things physically, but if we don't turn off the part of your body that's like, keep eating, well, then we can't create a calorie deficit big enough. And that's what we have to do. So I understand what we're doing, but sometimes when you start messing around with those hormones, things happen. So let's talk about, here's some new information. It's indicated for people with a BMI of 30 or a BMI of 27 with a comorbidity. It's the combination, like I said before, is naltrexone, which is an opiate agonist, or bupropion, which is an antidepressant. It's supposed to be used in conjunction with a diet and a weight management system. Surprise, I know you didn't see any of that coming. So let's talk about some of the dosages so we can get into the rest of the information. So like Qsimia, this also is a medication that you will change the dosages as the medication progresses. So week 1, this is a medication you give twice a day. Contrave, you will give twice a day. So week 1 is 1 tablet in the morning. That's it. Starting week 2 is 1 tablet in the morning and 1 tablet in the evening. Week 3 is 2 tablets in the morning and 1 tablet in the evening. And then after that first month, smooth sailing, baby. 2 in the morning, 2 in the evening. That's it.
Yeah.
The nice thing I will say about Contrave is that the extended release tablets are the same. You give more of them, but the tablets are always 8 milligram tablets. That's it.
True.
That's also nice. Like I said, each one of these medications, they got their own thing going. Like Belvique's only got 1. That was cool. Qsimia is kind of complicated, but it's working with some complicated medication, so I guess that makes sense. So, I mean, you just gotta work with them. Apparently, Contrave has also got some issues where, the word hypertension comes up a lot. Like, they really don't want you to give this to anybody with anything that's ever had something to do with their heart. So make sure you do a thorough history on your patient before you discuss giving them Contrave. So if they have ever had anything to do with MAOIs, pregnancy, so I know you weren't expecting me to say that either.
No, I was shocked.
Any known sensitivity to any of the components of Contrave, anything with seizure disorders, anorexia, bulimia, undergoing discontinuations from alcohol, benzodiazepines, barbiturates, or anti-epileptic drugs, they should also not be on Contrave. Blood pressure medications or anything involving the liver. This also has a warning for the angle closure glaucoma, as the Qsimia did, and anti-diabetic medications. So
Wow.
again, knowing your patient's history is going to be a very important part of the process before you can recommend one of these medications, and before you can move forwards in the process of, hey, how are we going to help you lose weight? So as long as you can safely tell your patient, hey, you have a history, like you said. So let's say your patient is a type 2 diabetic. Ben's sexy friend over there is probably the one that you might want to look into giving them, because if they could take a shot, that might be going with it. Or if they have like a history of liver issues, you definitely don't want them going with a Contrave. So I would say it's important for them to understand what the patient history is, because the other thing I was going to say is, if you look through the Contrave's adverse reaction, is again, you're going to see a lot of the same thing that we've talked about with Qsimia, that we've talked about with the Belviq: nausea, constipation, headache, vomiting, dizziness, insomnia, dry mouth. There's a few things with the Contrave that we didn't see, such as tinnitus, irritability, but otherwise we're seeing a lot of the same consistent,
Yeah.
throughout all these medications. You're going to see a very consistent, other than which I saw was pretty much with the Qsimia and the Contrave. And blood pressure seems to be very big with the Contrave, such as like if they do anything that's involving blood pressure medications. Not that I know why, if somebody was on a digoxin, why you would be doing anything like this with them, but certainly this is a no-go, or pregnancy, etc. But it's always important to know your patient's history before we move forward with these types of medications.
Some of the experience that I have with Contrave, both from hearing drug reps talk about it and then using it in the clinic, you need to be mindful if they're on any type of antidepressant as well, because of the antidepressant component already built into the Contrave, which is Wellbutrin is the other name for it, which we do use also for smoking cessation, and then of course the naltrexone, the opioid receptor, which in this case, according to some of the drug reps that I talked to, it kind of helps to curb late night cravings, is how that seems to help in this form. Funny story, I did have a patient come in that routinely seen another provider, and they were prescribed Contrave through a weight loss clinic elsewhere, and had come in for a refill on their hydrocodone, and they're like, I just don't feel like it's working anymore. Well, that's because you're taking Narcan. So
Yep.
if they are using long-term opioids, you need to be mindful that you're going to block any of that opioid use in their body. So just some other things that I've thought of.
Yeah, no, that's a really, I did not consider the fact that if they are on any sort of long-term pain medication, that Contrave should probably not be part of the conversation because of the naltrexone.
Yeah.
And again, though, like with the Belviq specifically, which is also, got the receptor issue, it specifically is saying like, hey, you really don't want to be messing around with the serotonin too much. Like we're already kind of tweaking this a little bit. So if they're already on any other medications that are affecting these levels, probably don't want to use this medication. And again, this is one of the few times I saw medications where the manufacturer went out of the way to say, hey, please don't give this medication if.
Yeah.
And I thought that was, I'm sure it is, but having studied these for this episode, I was like, wow, that was pretty cool. Where they were like, no, don't, please don't, please don't do that to us. I think it's important, and I know they're out to make money, but it did seem like they took the time to make sure it was thoroughly documented. Like, hey, this is what you're about to do. Don't give it if, and then listed each one of these documents is between 27 to 42 pages long of studies, actions, mechanisms, etc. So if you really want to break it down to the concentration of naltrexone and bupropion and contrave in the plasma protein bound percentages in your blood, by the way, it's 21 and 84% for contrave in your blood, you could find it. It's all in this information. So again, it depends on how much you really want to know. I suggest if you are getting ready to prescribe one of these things, it probably behooves you to look through some of this information a little more thoroughly. Again, we were trying to do something fun, New Year's resolutions. We want to make sure you guys had some really good information on some of the medications that were out there so that you could take a look and hear and understand some of the options you had available to you.
And a few things that I want to wrap up with, what I found kind of interesting on the on Up to Date, some therapies that were not recommended for weight loss.
Ooh, here we go.
Dietary supplements. Clinicians should caution patients against the use of weight loss dietary supplements and should monitor those who choose to use them. Over-the-counter dietary supplements are widely used by individuals attempting to lose weight, but evidence to support their efficacy and safety is limited. The FDA laboratory tests have revealed presence of fenpropirex, which is the bad part of fen-phen that got taken off the market because of cardiac problems, fluoxetine, furosemide, phenytoin, amphetamines, benzos, lots of different stuff in some of these over-the-counter dietary supplements. So it should be something that we are mindful of as clinicians. Second, that I thought was kind of interesting was the HCG diet, which I don't know if you heard of the HCG diet.
I have.
Okay, so injections of HCG have been advertised to aid in weight loss. However, clinical trials fail to support this claim. Several randomized trials have shown that HCG diet is not more effective than placebo in the treatment of obesity, and what they speculate that the reason the HCG diet works so well is adherence to a very low calorie, which is 500 calories a day diet, which has been recognized to result in short-term weight loss simply from the caloric restriction. No added benefit from the HCG. So, if your patients are on some of those, or if you as a patient are on some of those, then maybe you should look into some other potential options as we discussed. The last thing that I want to hit real quick, Tom, is sadly, the majority of insurances are not going to pick up any of the cost of weight loss medications. I personally think that's asinine. I think it's going to be much cheaper to treat the weight loss now than to treat the hypertension, diabetes, hyperlipidemia, everything else that's going to potentially come on later. But with that being said, off of GoodRx, I just wanted to pull some information just so you're kind of aware of some of the cost of some of these medications if insurance is not going to cover them. Phentermine, as it's the reason that it's most widely used is because it's the cheapest. Average retail price of it is $35 for a month. Contrave, you are looking at approximately $272 a month. Again, this is just through GoodRx. That's not to say that there aren't plans that you can get through with the drug companies. I know a lot of them will do some different things with that. Belviq, average retail price is $366. Quaisma, the average retail price is approximately $200 a month. And last, but certainly not least, the Saxenda, on average, $1,491.06 a month.
Well, that's a problem.
So again, but I do know that a lot of drug companies are very good about it's because they realize that insurance isn't going to pay for them, and so I know they get this medication for $3 a day or whatever the case may be. So as providers, make sure that you're aware of some of the systems that are out there through the drug companies to help your patients get these medications if they are deemed to be appropriate.
Yes, and I know some of the manufacturers themselves will set up through your pharmacy, or I want to say it's the Qsimia has like a direct link for like prescribers to send the prescription right to a pharmacy, so it'll save money for the patient. So
Yeah.
there are systems like that in place, as Ben was just discussing. I don't know about for $1,000 a month though. Good Lord. But
Right.
I mean, woo, I don't care how sexy that name is, man. $1,000. That's a lot of sexy. That's
Indeed.
ho,
Indeed, sir.
holy cow.
On that note, Tom, unless you have anything else to add to this episode, that's going to wrap up our dispensing of information on weight loss medication.
I think that's good.
All right. Well, if you like this episode and you want to hear more of episodes like this, you can find us on Facebook, Instagram, Twitter, and YouTube, all at Just Some Podcast. Our website is www.justsomepodcast.com. Email us. Let us know what you think of this episode or other episodes you think we may need to do. admin@justsomepodcast.com. All right, Tom. Well, that wraps up this episode, dude. It was good to have you back. Good to be back. And
It was good to be back.
it was. It felt right again, you know? The world's a little better off now. JSP is back on the air.
JSP's back in the air. Cats and dogs are living separately. You know, I mean, I was going to do the Bill Murray line from Ghostbusters, but never mind. I'm not going to do it. Yeah, so.
I was looking forward to it. I was waiting.
You felt the wind up, but I was like, no, I got my Serenity candle burning. I got one of those after that abortion story we did a couple episodes ago. So I'm calm. I'm serene. So there you go.
Good.
Yeah.
All right. Well, I don't know what we're going to cover next week, but I'm sure it'll be good.
Oh,
like
it's
most of our stuff.
Of course. Right? Yeah. Everything we do. Excellence.
Like an excellent adventure.
Yes. Ben and Tom's excellent adventure.
Excellent adventure. We might have just violated some copyright somewhere.
Yeah. Well, if they sue us, we'll get more publicity. So great. Hey, you know they're making a third one, right?
Yes, and I'm so excited. I can't wait.
I will go to the movie theater for that.
As will I. Yes. Excellent. So, on that note, be excellent to each other and have a great week.
Hey, everybody, stay safe out there.
Be excellent to each other.
Be excellent.
Practice swearing just to pass the time.
Yeah.
Lately I see why I am alone. I caught some road rage and I thought of you. And all the many times you say I should have known. Took a class so I could find my G. Found mediocrity's the best that I could do. Went to shower but I slept all day. It takes everything to live the life I choose. Oh, what do you say? I screw up everything again. Oh, what did you prove except there's only more for me to lose. Failure's not the same without you.